So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard.
What's good, fam? It's your host, Jimmy Pruitt, aka Pharm D and ED, and I'm bringing you another episode of the Pharm So Hard podcast. Today, we have a special episode that we're going to be recording because it's going to be something that I love. I think all of us that works in ER are going to be super interested when it comes to just doing things in cardiac arrest. And I wanted to highlight some pharmacist-driven work that's been done out in the community. And I'm just super excited to talk about this one particular research project that was done by Kyle. But before we dive any deeper into all of this, can you just tell the audience a little bit about yourself?
Yeah, absolutely. Thanks for having me here today, Jimmy. It's great to be here. So a little bit about myself. I was actually born and raised in Duluth, Minnesota. So for those who don't know where that is, it's northeast Minnesota, right on the tip of Lake Superior, approximately 2 hours north of the Twin Cities. I did my undergraduate studies and my pharmacy training at the University of Kansas in Loris, Kansas. So Rock Chalk Jayhawk to my fellow KU grads that might be listening right now. After pharmacy school, I completed my PGY1 pharmacy training at Mercy Hospital in Springfield, Missouri, and my PGY2 training in emergency medicine at Sarasota Memorial Hospital in Sarasota, Florida, which I completed in 2021. And then after that, I stayed on at SMH as an emergency medicine and clinical pharmacist, and occasionally I float and staff up in our ICU as well.
Cool, man. Thanks for letting everyone know about yourself. And I think anyone who knows anything about emergency medicine pharmacists in general, we know that Sarasota, again, their hospital goes back to the original ED pharmacist study that was done by Terry Fairbanks and all of them. So the original pharmacists that were officially trained when there was like 2-3 pharmacists, pharmacy residents out there. Again, these were kind of I call them the OGs of ED pharmacy. So the work you guys been doing down there has been superior for a very, very long time, dating back to the 1990s. So excited to have you on to kind of be a representative of that. But I want to kind of shift and let's talk today mostly about this study that I was kind of blown away by. A lot more so from just the work that you guys did to get to it. So the study that we're going to be talking about today is going to be Esmolol vector chain dose-capped epinephrine for pre-hospital ventricular fibrillation or pulseless VTAC. And of course, we have the primary author here to talk about all the deets when it comes to this, because I think that research like this is substantial. One, because this is something that if depending on how this thing goes from this study that we're talking about, we can be changing a lot. And one study sometimes can change a lot. And I think as we look at work that's getting done in cardiac arrest literature, it's not necessarily always represented by PharmDs, even though we're doing some of the work. So that's one thing I want to kind of highlight. But again, like I said before, tell us about your journey and what led you into like research in general in EM.
So this project specifically was part of my training, obviously, for my PGY2 EM pharmacy residency. I didn't have like a huge research background from undergrad or as a pharmacy student, but it's always something that I've been interested in. More specifically, in emergency medicine, I had an interest in resuscitation. So these concepts that we looked at in this study, esmolol, vector change, those adverse effects of epinephrine that we see in this refractory VFib, pulseless VTAC patient population weren't something that I was super familiar with coming out of pharmacy school. So as I began to learn about those concepts during residency, I really did find them fascinating. And I felt like there were some significant gaps in literature. So there's a possibility that I could find something more meaningful. So really when this research opportunity presented itself to me during residency, I just jumped on it and dove right in. I was really excited about the fact that it was a pre-hospital study. I was going to be working with EMS and collaborating and forming those relationships. And then additionally, it was going to be a multi-center study, which isn't something that I ever saw myself doing in my career, let alone as a new practitioner, as a resident. So I was really excited just to kind of get the ground running on this project as a resident.
Yep, that's phenomenal. Because again, something so substantial when it comes to research being done, multi-center. Most people won't even think about this, and that's why I want to highlight to a lot of people the significance of having a pretty established ED pharmacy program to begin with, because I lean on them, they've done work before. Again, I've met, again, countless pharmacists that's either worked there in the earlier days, but again, that's kind of the foundation and the collaboration that it takes to really get that, because those relationships with pre-hospital wasn't built overnight. Those relationships with the physician, things like that wasn't built overnight, but established ED pharmacy services really, I think, was a big thing when it comes to that. And you kind of jumping in there with eagerness to do this is phenomenal, because again, we can probably count only a handful of pharmacists in general that's done multi-center studies, in particular in this manner. All right, so enough fangirling about your program, fangirling about the fact that a pharmacist actually did this. Let's actually get into the study on the use of esmolol and vector change and dose-capped epinephrine, and let's break it down for the listeners, because some of them may not have saw it. Because the first thing, I was writing a book at the time that I saw this come out, and I was like, oh my God, I have to kind of break this down. So first, just the very basics. Tell us, what was the primary goal of your study?
Yeah, so our study evaluates an EMS protocol for patients in refractory VFib, pulseless VTAC, cardiac arrest. And that protocol includes esmolol administration, vector change, defibrillation, and capping the total dose of epinephrine at 3 milligrams. So a total of 3 doses. Before I get into like the primary goal and objective of the study, I do feel like I should touch on the background on how this protocol kind of came to be. So, like I said, there's 3 main parts to it. The first intervention being esmolol, beta-1 selective beta blocker. Esmolol is thought to be beneficial in these patients because it helps to overcome some of those harmful effects of catecholamines that we can see in these patients. So they can cause an increase in myocardial oxygen demand, lowering of the VFib threshold. So epinephrine is pro-arrhythmogenic. So why are we giving it to patients that are in a fatal arrhythmia? So sometimes those adverse effects can really limit the success of our standard ACLS intervention. So the 2 main studies kind of in the background of all this that showed benefit were published in Resuscitation by Driver and colleagues and Lee and colleagues. These 2 studies were very small in retrospective, but did see significant increases in ROSC in those patients that received esmolol. So that's the background behind that first intervention. The second intervention being vector change. So vector change defibrillation kind of describes the changing of the defibrillator pads from standard anterior-lateral location to an anterior-posterior location. So the thought behind that is that it allows for a greater delivery of electricity to the entirety of the heart. We had some preliminary findings and data that found that showed promise in improving outcomes with vector change defibrillation in these patients. And then now, obviously, with the recent publication of the DOSE-VF trial in the New England Journal of Medicine, this practice, at least at our institution, has become a little bit more mainstream. But that was after my study came out. And then the last intervention was capping the dose of epinephrine. So older studies suggested that higher doses of epinephrine administered to patients in cardiac arrest due to shockable rhythms are associated with poor outcomes. And this was kind of confirmed or validated in more recent studies. So the Paramedic 2 trial, there was a subgroup analysis of patients with shockable rhythms that didn't show any survival benefit in patients who received epinephrine compared to placebo. So really, with all of that evidence in mind, our local EMS agency implemented this 3-part protocol, utilizing all of those interventions. EMS protocol personnel were able to implement vector change, hold additional doses of epinephrine once patients met criteria for refractory VFib, pulseless VTAC. And then EMS captains were actually contacted to approve and administer esmolol in the field. So the thought was that if each of these interventions improves outcomes individually, they should also improve outcomes when utilized together. And really the primary goal and outcome of this study was to evaluate the effects of this protocol on sustained ROSC, which we defined as ROSC that lasts for at least 20 minutes.
Perfect. And just so intriguing kind of when I hear this, like, as I'm like thinking about this and like reading your introduction, kind of going through getting all this data and realizing, hey, we potentially hasn't been doing cardiac arrest the best way you possibly could because of the because of the data we found on the dosing of epi or all these other things. And Esmolol, like, super exciting. And I think every time I bring Esmolol out, endocardic arrest, it's like, oh my God. I remember one time I had a case where he gave it. And he was like, what was that drug you just gave? What was that? This is amazing. So kind of having that background and having the data and then seeing how that led to this, I was super intrigued. But a lot of us like to nerd out, right? A lot of us want to get down to the nitty gritty. So we know you told us some of the background and you told us kind of your main goals, but can we dive a little deeper into how you actually approach this and what does that actually look like in your method session?
Yeah, so our study itself, multi-center retrospective cohort study. I do have some more specifics on our methods discussed in the publication, so feel free to ask additional questions if you really want to get into the nitty-gritty of things. But I do want to focus on a few main aspects of our approach that I feel made us successful, and some of the challenges that we did face when we were conducting this study. So really our first main success was having a great relationship with the medical director of our local EMS. And you really touched on kind of how established our EM pharmacy program is. And I was really lucky to be able to benefit of those relationships that all of those pharmacists formed before I came to Sarasota Memorial. So our EMS medical director, Dr. Frank, one of the authors on the study, was extremely engaged, helped provide any resources that he had available to us to make this project a success. One example I can think of early on when we were first meeting as a research group, we were thinking of ways to generate our lists through the EMS electronic health record. So he got us in touch with EMS IT workers to develop our screening lists for both groups so that we could easily go through those lists and include or exclude patients for our study. And then we also had an amazing nurse through EMS that helped collect our data so that all could be input into our REDCap data collection tool, which really is kind of the second aspect of our methods that helped make this project successful. So my residency program and institution utilizes REDCap. For those who haven't heard of it or might not be familiar with it, it's a data capture application that helps you just gather and organize data in like a secure location. So essentially, I was able to create a survey of like yes or no questions for which outcomes I wanted to look at for my patient population, like free text answers if I was looking for specific number entries or places that the data collectors could input like dates and times that specific outcomes were occurring. So if I was looking at time to event, I had all of that information in REDCap and it would calculate all of those timings for me. But I think the most useful aspect of REDCap is that I could share this data collection survey with other people using their email, and then I could limit how they interact with my project. So for the multi-center aspect of my study, for hospitals outside of my institution, I could share my project with whoever my contact was for them to input data only. That way I didn't have to worry about sharing Excel spreadsheets or losing sensitive patient-related information when I was going back and forth with them. So I think that was one of the major things that made this process a success when I was coordinating it. That brings me to my biggest challenge was coordinating the collection of all of this information from multiple sources. Since it was a pre-hospital study, I didn't have any control over where patients were transported to from the field. A majority of patients did come to my institution, luckily, which was great. I could just access their patient charts, just like any other retrospective chart review, and find that information that I needed. The tricky part was when patients didn't come to my hospital. So once again, I utilize my connections with local EMS. Every EMS agency, I'm sure, collects quality data from the hospitals that they transport patients to. So they do have contacts with people at all of the hospitals in the area of people who collect data for them. So I use those relationships that were already there. That's something that our research group discussed early on in case outside hospitals didn't necessarily feel comfortable sharing information with me. So we actually met with our hospital's legal department. We drafted a data use agreement, which essentially is a kind of uh, document that kind of outlines how we're going to share and use data with each other. Additionally, we gathered documentation from IRB, just to show that our project was vetted, and make people more comfortable with sharing data with me. When those connections through MS failed due to lack of resources, or they just didn't have the bandwidth to help at the time, we would use connections through the pharmacy department to find pharmacists at these other institutions that were willing to help collect data for us. And once again, this was made really easy with REDCap, just sharing that survey. They would input the data, and I would have that just at my fingertips when it was coming to analyzing the data. So I think those are the main successes as well as challenges that I had. But if there's anything more specific about the methods that you want me to discuss exactly how I did it, feel free to ask.
Yeah, I think that's because most people can kind of read those things. The thing that you can't find in the method section is like you mentioned, some of these things that were great that we should be focusing on. And I wish it was an area where we can put in the supplement and say, hey, these are some challenges you may have. And if you can limit these things from happening, or if you can use REDCap or use a particular type of data software, this would be extremely helpful for you. So I think just mentioning some of those things, and again, the challenges as well, it's super helpful, because again, most people that go into this don't know where to start. And they don't know where to start, and they don't necessarily know what challenges will come up. So I think us mentioning when you're designing all of these things in relationships you need to have, how important it is. So I think that's a huge thing. So again, you guys go read the paper, dive a little bit more into some of those things to geek out on. But again, this is one of those, again, respective chart reviews to look into what was done in the field and how that actually led to an outcome. All right, so we're now down to the big part. We kind of hit some of the background. We hit the methods of it, in particular, some of the challenges and some of the things that went well. Now people want to say, hey, you guys found all this stuff beforehand. You did all this amazing stuff. You're Kyle's a phenomenal researcher and pharmacist. What was the outcome?
So initially, we hypothesized that the EMS protocol bundle would lead to improved outcomes, but we actually found the opposite of that. So patients within our study were less likely to achieve ROSC, achieve sustained ROSC, as well as survival to hospital arrival. With regards to survival at discharge and neurologically intact survival, the rates of those outcomes were small and similar between groups. There are some key differences in our two study groups that I do want to highlight. So first, patients in our pre-group, so like our controls, those that did not receive our protocol bundle, had numerically higher rates of bystander AED use, and higher rates of initial shockable rhythm. So as we know, early defibrillation improves outcomes, and as we know, the incidence of non-shockable rhythms tends to bring poorer prognosis. Also, patients in our post group, obviously by the nature of the protocol, received less epinephrine as a result. And as we know, administration of epinephrine does increase the rate or increase the incidence of ROSC. So those are some of the main reasons why we think we found these results. It's definitely not what we were expecting. I was a little disappointed personally for myself, but that's what we found.
Yeah, that's amazing. Like, as we think about this and we go into it, we definitely didn't expect it to be a quote unquote worse. And you mentioned some of the key things that people really need to kind of pay attention to. And because what I don't want to happen, people say Esmolol kills people, or the lack of getting epinephrine hurts. And I think when we look at this, one of the things I saw is we had 126 total people in that study period, I believe, and then a few of them didn't necessarily meet the definition for refractory VFib. So again, when looking at your numbers, things of that nature, of course we thought we'd be able to find something, but again, from my perspective, just the fact of getting the AED use, which has a number needed to treat of 4. We're talking about like one of the best interventions in cardiac arrest. So mentioning that, the study size, that's definitely something that I pulled away as, okay, let me not get too overwhelmed with the information and really just talk about how some of those other factors kind of led to this, but not to de-emphasize the role that pharmacists had in this. And like what happens now? Again, you already got a relationship, you know how to do the research. If this is tweaked or someone else want to kind of pick up the baton and it has a little more time as a resident or something like that, these things can be tweaked and kind of looked at. Because there's a ton of things I'm like, man, I'm pretty sure what really happens behind closed doors and how long this stuff takes, and whether everything was done exactly as a protocol set each time. All those things kind of pop up in my head when I think about all the work you guys did to design all of this, and whether it looked different in a more prospective RCT like kind of perspective. So that was my approach on looking at all of this. Really want to kind of see, as you mentioned before, you mentioned again, it's not necessarily something you expected, but again, any additional commentary on as far as like why the results came to where they came out, or again, we'll talk about the next question after.
Yeah, I think there were just some minor differences in just like the baseline characteristics or prior interventions that each group made. Additionally, also, so this is kind of a pre-post study, and the protocol was implemented in, I believe, December 2019. So you've got to think that's right before the COVID-19 pandemic as well. So just our EMS ability to respond in the field and those practices did change. So there's going to be some differences in how they're responding to these medical emergencies as well.
Yeah, and you just mentioned something pretty key as well, because again, I remember at one period of time there's some studies coming out, people that just had COVID in general, they did have these shock rhythms to begin with, and they had like 97% mortality. It was like really, really, really crazy. So again, you may have some of those patients in that bundle as well. So I think we kind of get a different time frame. We don't have the sickest people and have a epidemic going on. We'll definitely probably find something different. But another cool question I want to kind of ask, kind of shifting from this in this hypothetical scenario. Let's just imagine for a moment you had like no limits or on resources. What further research would you pursue in this area?
Honestly, if I had no limits on resources, I just feel like replicating the study like a large randomized control setting would be amazing. And really, you could apply that to any research question you have in emergency medicine. Essentially, if we're thinking pre-hospital, just take the methods from the Paramedic 2 trial and apply it to any of the interventions that we looked at in our study. And if we had all the time in the world, no limitations, that's probably what I would do. You could actually evaluate more meaningful outcomes instead of just ROSC or sustained ROSC. You could look at survival benefit, neurologically intact survival benefit, and actually like enroll enough patients to be able to detect a significant difference between groups. So I think just large scale, randomized, controlled, prospective would be the way to go.
Absolutely, man. Kyle, again, thanks for your insights today. It's been phenomenal in kind of taking us through kind of the background of this research study, the methods, the results, and realistically, what would be the best possible case scenario. And if we think about what that unlimited resources presentation or study would look like compared to this one, you start to kind of say, okay, hey, we didn't find anything that we wanted to, but realistically, if we had a few more resources, a little larger sample size, maybe we'll get there. So I think it's clear that, again, pharmacists can actually benefit in this part. I think a lot of people kind of recognize that, but I think the bedside pharmacists, the one that's actually doing these cardiac arrests from the field, those are the people who can actually play a significant role with cardiac arrest literature, and I'm just super excited to have pharmacists as a part of that. But before we close out, any parting words for any of our healthcare professional listeners when it comes to this study, research in general, or just emergency medicine?
Yeah, so I know as we've discussed today, my study in particular, it may be small, it may be retrospective, it's definitely not a randomized control trial, but I still never imagined that I would oversee a project to this magnitude in my career, let alone as a new practitioner, as a resident. So I guess my best advice for listeners would be to find an area in pharmacy or medicine that interests you, stay curious, learn the literature, ask those meaningful questions that could potentially lead to meaningful outcomes, find other people that have the same passion as you, collaborate, and you can really accomplish anything, especially since pharmacists are experts in pharmacotherapy. I think it's really important too that we're involved in those conversations. We're in the room, involved in research when it comes to pharmaceutical innovation and research. So it's really important that we're involved as well.
Yeah, super inspiring, man. Super inspiring. Just the fact that you was able to do this. Again, I kind of fangirl quite a bit just thinking about like all the steps that it took to get to this point. And I'm pretty sure there's many sleepless nights and frustrations and everything in between to get to this point. And I think it just shows that, again, the bedside pharmacist, no matter what part of your career that you're in, can really make a significant impact. And literally all it took was a few patients turning the corner here or there for this to be something that may be included in the guidelines moving forward. So I think that we don't want to de-emphasize the importance of the framework that was built by you guys and what happens, again, even if it's a slightly larger retrospective study that someone picks up because they hear this. So I think this is huge work. I'm thankful for you guys, the program, all the things that's been built there. Just excited for emergency medicine in general, and that's kind of why I want to close out on just the excitement of 2024 of what we can do. Again, for you guys who are unaware of the Empower Arts Conference that's going to be in Charlotte, April 20, 26, and 27. That's going to be, again, it's the Emergency Medicine Pharmacotherapy with Resuscitation Conference. So I think topics like this and things of that nature will be displayed there, and really just a place for all of us to kind of come together and meet all the people who we've been super excited to read about. So I'm going to close out with that, guys. I thank you all for listening. Kyle, thank you for coming on and spreading your expertise. And I'm going to close out the same way I do every episode, guys. You don't have to be a pharmacist. You don't work in an ED, but everything you do, make sure you farm so hard.